Welcome everybody, coming to you from Texas, from Houston, from Texas Medical Center, from Methodist Hospital, from DeBakey, what's called CVNOW, it was CV Live, CVNOW, and we are going to discuss atrial fibrillation. I'm your host. I'm Dr. Randall Wolf. I have a guest with me, which we will introduce in a few minutes. To bring people up to speed, we do this once a month on Tuesdays, but not during the summer, so summer break is over. As Don Henley said, recess is over. That was a song Johnny can't read. But anyway, back to the important part. We're going to talk about atrial fibrillation. We have a program here at DeBakey, a surgical AFib program. We'll be discussing that. We will take questions, and I should say we are taking questions. So I recommend you get your questions in early. And to do that, you can either go on your computer or your phone. If you're on your phone, you go 37607, that's 37607, text DeBakey and text in your message, your question. If you're on if you're on your computer, go to pollev.com, that's pollev.com, enter DeBakey, and then ask your question, respond to the activity. So those are the two ways that you may ask questions, either to me or my guest, or both of us. Also, we have a new option. I've been told by my producers that if you're seeing this later on, in other words, not live, you may also pose a question, and those questions we will try to address the next month. So that's for the people who watch this on DeBakey, YouTube, DeBakey YouTube, after the fact. So when it's not live, you'll still have now an option to ask a question. But I recommend you try to ask the questions now because we're live. And I will try to get to all your questions, either by ones you ask on the computer or your phone. It can be anything about AFib. All questions are fair game. Don't hesitate. Don't be embarrassed to ask a question. So we're back on. Usually it's the first Tuesday of the month at 5 p.m. Central Time here at Texas Medical Center. East Coast would be 6 p.m. And we'll continue that here probably throughout the winter. Is that right, Mr. Producer? Once a month. And we did the second Tuesday this month because I think Tuesday was the day after Labor Day last week, so we pushed it off to today. So that's the housekeeping stuff. There are a couple of things I wanted to share with you. I have a new video. It's one that I presented in Dallas about a month ago. It was the Dallas AFib meeting, Get in Rhythm, Stay in Rhythm. Melanie Truehill's meeting went very well. I presented on Saturday, and I believe that's also online now as well. And I have a 30-second video that we'd like to share with you, and then we'll talk about it a little bit. So, Obed, when you're ready, you can go ahead and cue that up, and we'll run that 30-second video about how I look at AFib, which is a little different than the way most people look at AFib.
An important component of the intrinsic cardiac autonomic nervous system consists of ganglionated plexi, GPs, located within the heart wall. Most of these GPs are located superficially, and they interconnect with deep GPs situated closer to the endocardium.
Can the audience hear it?
Transmural ablation of GPs around the right and left pulmonary veins achieves partial isolation of the GPs and inhibits transmission of signals to the rest of the heart, resolving symptoms of arrhythmia, as opposed to endocardial catheter ablation, which does not target nor reach most GPs.
So this is a key concept of the way that I look at AFib, and it's different from the way that AFib is generally perceived. Generally, what's perceived is that there are abnormalities in the heart muscle and the heart muscle needs to be either burned or frozen to stop AFib. And I think that's kind of at the end of the system of AFib. So it's almost like the horse is out of the barn. To me, the way to attack AFib is to go to where it starts, which is in the nerves that are on the outside of the heart. Catheter ablation attacks the inside of the heart, but the surgical ablation that we do here, that I do here, focuses on the outside of the heart where the nerves are, and that is what was depicted on that video that you just saw. These GPs, or ganglionic plexi, are the sort of the end of the little nerves around the heart. They get their instructions from your brain. These are the nerves that make your hands sweat when you look over the edge of a tall building, if some of you know what I mean. Or say you're watching a scary movie. You're sitting in your chair in your living room watching a scary movie and your heart rate goes up. Why? You're not running. It's again, those are signals from your brain that you're programmed by thousands and thousands of years of evolution to increase your heart rate just in case. And those are the nerves that can get your heart out of whack. You also have nerves coming from your spine called the sympathetic and parasympathetic areas of the spine that also go to the heart. And all these little nerves are converging on the left and the right atrium. And if the signals are unbalanced and too much, that's what puts your heart out of rhythm. So those abnormalities are best addressed, in my opinion, by going to the source, which is on the outside of the heart. And that's really why I think the Wolf procedure works. First question, for someone with paroxysmal AFib who only has 1 to 3 episodes per, I don't know if that's per week or per year, I'll have to sort of guess what the end of that sentence is, but let's say you have 1 to 3 short episodes per year. Do you need to do anything? Well, maybe not. The treatments for AFib continue to be nothing, medication, catheter ablation, or the Wolf procedure or some surgical procedure. I don't do it on pump. We don't go through the breastbone, but some people do the procedure with the heart-lung machine. Some people go on pump with the heart-lung machine and go through the breastbone. So those are your choices really to treat the AFib. Now, I think the best way to look at this, if I'm getting to your question correctly, is to be very objective about it. What does that mean? Objective means how much AFib are you really having? Are you really having 1 to 3 short episodes? Or maybe the heart's going out of rhythm in the middle of the night, you don't know it. So whenever there's some question, I'm a big proponent of putting in a continuous monitor. I use the Medtronic one called the Link. Boston Scientific makes one. Abbott makes one. There are different manufacturers. I stick with Medtronic because we have that software in our computers in the office. And this will send an EKG to me every day through your phone for 5 years. You don't have to hit any buttons. It does it automatically. And is very objective. And it will document the percent of time that the heart is out of rhythm per month. And if it's less than 5%, maybe you don't need to do anything. But once that percentage gets higher, or if it goes to 100%, then it's best to probably do something about it. It needs to be treated. So the treatment can be starting on an antiarrhythmic. Some of them work pretty well for a while. Most of them will fail eventually. Some of them are more toxic than others. We've talked about that before on this program. Catheter ablation is a possibility, or the Wolf procedure is a possibility. None of them are 100%, but I can assure you that what I do is 100% better than a catheter ablation in terms of staying AFib free. I have patients out 23 years now. Let's see. Can you explain why edema is common after the procedure, and if clamping the LAA has anything to do with edema after? Very good question. And I think the answer probably does have something to do with the left atrial appendage. The left atrial appendage is closed during the procedure. That's where most of the clots form. So by closing it off, it dramatically decreases the chance of a blood clot coming from the heart. Even if, and with a clamp, it doesn't matter if you're off blood thinners and you have an episode, you won't have any blood clot that comes from your heart. It decreases the risk of stroke from AFib by 97%. That's by clamping or closing the appendage. But it also electrically isolates it, which is not done with the other techniques such as the Watchman. The Watchman device does not electrically isolate the left atrial appendage, which I think is also important. But the left atrial appendage does have some hormonal activity, and it has to do with the kidney function. And it is true that clamping it can cause edema for a while and cause patients to hold on to more water temporarily for a week or so. What I try to do is not only clamp it, but cut the tip open to let any fluid, any blood inside drain out. And the thinking is it won't be distended. And the way these hormones are released is when the left atrial appendage gets distended, it releases more hormones, and those affect your kidney output through what's called a renin-angiotensin system. These are hormones that affect the kidneys, and it's a complicated system, but the short answer is yes, I think you're right. Now, we're very fortunate to have with us today Mr. Trent Adams. He lives about halfway between Los Angeles and San Diego. He has a history of AFib that he's been fighting with, and he'll share it with us. He did come to see us about 5 months ago and had the Wolf procedure, and I think it'd be best to let him tell you his story. I may interrupt him from time to time to amplify on any point that he has. I want to thank him from the bottom of my heart for coming on and joining us, which is a wonderful thing to do, and I think that's not something that everybody does, but it's great, Trent, that you're willing to do that and share with us. And Trent even said that if you'd like to contact him after this show, you may at Trent at losadams.us. That's TRENT at losadams.us. So Trent, welcome to the program. Welcome to CV Now. And please introduce yourself and share your story with us.
Well, thanks, Dr. Wolf. Appreciate that. It's an honor to be able to be here and tell the story, and just what a great way to sort of cap off the experience that I've had for this year from a medical standpoint. What a year it's been for me. I'm 57 years old. I've always been healthy, never had any issues of any significance from a health standpoint. And then a number of years ago, I started to feel the shortness of breath and the sort of, as I call it, the cattywampus beat in my heart. And I had no idea what it was, even though my mother had AFib and I'd heard of it. And even my sister had a form of it. She had SVT. I just had not been really paying attention. And fortunately, I was working out with a friend of mine who is a heart device engineer for I think it's Edwards Life Sciences or something. And when I told him about the symptoms, he goes, "You're an idiot. Go get an Apple Watch and check your EKG." And I had no idea I could do that. So I did. And the next time I felt the symptoms, I sure enough checked my EKG, and I was kind of thrilled. I'm like, hey, this thing really works. But darn, I have this thing going on. And somewhere in that process, before I knew what it was, I'd had a stress test, and it came out perfectly because I didn't have, it was paroxysmal. It was only occasional. I wasn't in AFib at the time. So it took us a while to kind of figure out what was going on. Ultimately, I ended up having a catheter ablation that lasted maybe a year. And then, it went back out of rhythm after that. I guess it didn't take. And so I went and I had it done again by the same doctor, the same EP. And after about 3 months, the symptoms came back kind of with a vengeance. They came back really strong. And I guess this guy was about to retire, because I'm sitting in his office after 3 months and he goes, "Well, I've done 2 of these on you. Looks like it didn't work. I'm not doing a third." And he summarily, basically he fired me. I got fired by an electrophysiologist. So
now, Trent, did he give you what were the options he gave you at that point?
He wrote down the names of 3 other doctors and sort of dismissively handed them to me as I walked out of his office. I was kind of stuck. Fortunately, at that moment, it was just about, I think, a week before my second ablation that I learned about you. It was just a serendipitous event that happened where I met a fellow in the park while I was doing some photography. He was an old Indian fellow, and he asked me if I would do some family photos for his family, because I do some portraiture on the side, and I did. And in meeting and talking with him, so the subject of AFib came up, and we realized we both had it. And he told me he had found a guy that had built a better mousetrap. There's this guy in Houston named Dr. Wolf, and let me send you some YouTube videos. And I went, "Oh, great." So, a couple of days before I'm going to go in for my second ablation, I'm watching all your videos and I'm second guessing the whole thing completely.
Oh boy.
I almost canceled it, but I went ahead and went through with it anyway, since it was scheduled, got it done. And, the rest is history. I after it didn't work, that's when I called you and got on my journey to come back and see you in Houston.
And that was about 5 months ago or so, is that correct?
Yeah, February 3rd was my meeting with you. That's when you
and at that point, for everybody listening, at that point your heart was out of rhythm continuously, correct?
That's correct. So I had one cardioversion a year ago, August, that lasted for maybe a month, and then the AFib pretty much became chronic. And I knew I had the appointment set with you, so I was just taking the medications, the metoprolol and whatever else it was.
Do you recall if you were on an antiarrhythmic at that point? Now, I probably started you on amiodarone a couple of months before.
That's right. You did. It was amiodarone that you had me on, right?
Did that settle things down any?
It sometimes worked and it sometimes didn't. But what I noticed is it just, and people out there might kind of identify this. When you have it paroxysmally, as in every once in a while, you think that you can maintain it. You think you can, well, maybe if I do this or if I don't do that. You learn about certain triggering things. Like for me, it was either a really heavy meal or that one extra drink. If you have 2 instead of 1, one extra glass of wine knocks you out of rhythm. But it just does. There's nothing you can do. You got to go get fixed.
Yeah.
It doesn't get better by itself.
That's right. Now let's go back, Mr. Producer, just to the join by web or text one more time. If you're listening to us live and you'd like to ask a question, you may get in the queue right now. It's 37607 on your phone, then text DeBakey and then give us your question. If you're on your computer, go to POLLEV.com. That's POLLEV.com, enter DeBakey, and then ask your question. And we'll continue to work in questions as we go along. So Trent, you got to the point where you were out of rhythm all the time. And my guess is you had some symptoms at that time?
Really, the only symptoms were shortness of breath. It was just it was an annoyance more than anything, but I knew from reading up on it enough that this is not a condition that you want to live with. I guess there are people that do live with it for years and years, and even some people who live with it because they don't even know they have it.
Well, you're right.
I can always feel it. I can feel when I would go out of rhythm, and then of course using my Apple Watch, I could always check and see when I was out of rhythm. And so the wearables, as far as that technology go, what a great thing. It's a really handy thing to have, and you can figure out what's going on pretty quick.
Well, the awareness of AFib has increased exponentially since the wearables. You're right.
I would guess.
Apple Watch is probably number one. Cardia is popular, Kardia. You can put your fingers on a little plate and you get an EKG on your phone, which you can email to your physician. They are not 100% accurate. They suggest AFib. They can't tell the difference between AFib and aflutter. And most people who have had 2 ablations, in fact, exhibit mostly aflutter, not AFib. I don't remember if you did or not. Do you recall?
I don't know that I ever had aflutter unless it was post-op, as the heart was healing.
Yeah.
But you're right. I just knew what my watch said. But the only other times that I had EKGs at the doctor's office where it said something was actually with you.
Yeah.
So I just knew that I had something going wrong because I could feel it, and then the wearable was telling me.
And nothing against ERs because they do a lot of tremendous work, but they have to sort of just figure out if someone has an arrhythmia. So oftentimes they'll say you're in AFib or you're out of rhythm, and it may be flutter. And the EKG may even say AFib, but a learned person, such as an EP, may look at it and say, no, that's definitely flutter. So the two are confused quite often. But generally, atypical aflutter is mainly seen after catheter ablation. And I think it's because the scar is created, and it's an incomplete scar. So some areas are scarred, some aren't, and that actually leads to more aflutter. We never saw left atrial flutter until, or very rarely until after catheter ablation, but now it's quite common. Catching up, now you come to Houston, you have the procedure, and I think we ought to go ahead and talk about the fact that you had, I guess I would call it a complication, but it's something we know happens from time to time. From 1 to 5% of the time when someone has their heart sac open, and for the audience out there, all mammals, doesn't matter whether you're a squirrel or a rabbit or a human, you have a sac around your heart. It's a protective sac. It lubricates the heart as it moves. It protects the heart from bacterial infections and viral infections, much like the brain is encased in a membrane that protects it from infection. Well, the heart has that too, and it's called the pericardium. And in 1 to 5% of people who have the pericardium open, the heart sac open, for one reason or another, they will develop inflammation in that sac. 95% to 98% of people don't, but 1 to 5% will develop inflammation. And what I do routinely is treat everybody if they're maybe going to have inflammation in the heart sac. That's why we use steroids intravenously right after surgery, and we use steroids orally, like prednisone, for about 5 to 6 days after the procedure to try to hit it hard, decrease the inflammation, and sort of nip it in the bud, if you will. We also use colchicine, which is a drug that's been around for ages. It's used to treat gout, but it's very good at decreasing inflammation. And we found by using this prophylactic, that means to do it before something happens, this prophylactic regimen, we've been able to decrease the chance of inflammation or pericarditis. It's the pericardium. If the pericardium's inflamed, it's called pericarditis. Reduce the risk of this post-operative pericarditis dramatically. Nevertheless, despite all that, Trent, you had that. You got it.
That's right. I was the lucky one in the low percentile, and for me, it was presenting as flu symptoms. And my whole experience back there in Houston was great. Everything went as advertised. Recovery was quick. Got home, everything was good. But then I kept getting these strange flu symptoms, and my doctor here couldn't figure it out. And finally, after it came back the third time, he sent me to the, or I guess the fourth time, he sent me to the emergency room, and they did a whole battery of tests and couldn't find anything. So that was a Thursday before Easter. And then on Easter Sunday, it came back with a vengeance. I got 103 fever. My symptoms, by the way, were a high fever, bone rattling, teeth chattering, chills, night sweats like you can't believe, like we got to keep getting up and changing the sheets kind of night sweats, put down a towel for crying out loud. And then just generally feeling tired and in malaise. And so by the time I got to the ER at this second time, I figured, they would certainly be able to find something because it was completely florid. And, they just did all their tests again. And then they said, okay, well, we're going to admit you and do some more tests. And I knew from experience that I was, near the end of this cycle. And so I allowed them to admit me just to see if we could find out anything. And this story has another sort of moral to it, but the thing is that a cardiologist did come to visit me in my hospital bed, and he sort of jokingly suggested that maybe it was this thing called Dressler syndrome. And I see you have the infectious disease doctor coming in to talk to you. Why don't you joke with him and say you think it might be that? Well, we looked it up, and I had all the symptoms. I checked all the boxes, and we went, oh, of course it's that. But the infectious disease doctor said, no, it can't be that because you've gotten it 4 times. It doesn't come back. So turns out that when you're dealing with something, anything medical of significance, you really, really want to make sure that A, you go to the best doctors you can get, and B, that you are kind of your own doctor. I joked with him. I said, hey, we've kind of nullified your entire medical career because we have AI and YouTube. And he didn't think that was very funny. But it's kind of true, right? I mean, you can figure out so many things more than you ever could before. The resources are so amazing. And so once we found out that it was Dressler, it was like, oh, yeah, take the methylprednisolone and the colchicine. And it was very effective treatment for getting that done.
Well, to your point, one of the ways to diagnose Dressler syndrome is to take steroids, and usually within 24 to 48 hours, you're a new person. Is that what happened to you?
Yeah, absolutely. But at that particular stage, when I got out of the hospital, I didn't talk to you and get confirmation of the Dressler until about a week later. And that's when you prescribed me the medicines. And since I was feeling good at the time, I didn't want to take any medicine, but we just put it on the shelf and waited. Started to get symptoms again of the Dressler. And I immediately took the steroid and the colchicine, and it stopped it in its tracks.
Yeah.
And that's been, I don't know, since Easter. So I think I'm through with that.
I think so. It's unusual for it to recur. Nothing's 100%, but be unusual, but it can recur. So Dressler's syndrome is post-pericardotomy syndrome. The pericardium, otomy means you opened the pericardium, the heart sac. So it's post-pericardotomy syndromes or Dressler's syndrome. That's exactly right. Now, give us an update on, there were some questions too. I guess this question's for you, Trent. They want a little more information on the recovery process. So how long were you in the hospital? Were you able to do usual activities, increase your exercise? What was your experience?
Sure. So I was even, before I went into the hospital on the Saturday, before the Monday procedure, I walked 6 miles, got to know the Houston Medical Center area really well. And then Monday was the procedure. I was out and back into we actually got an apartment instead of a hotel by Wednesday night, and I was moving a little bit slow. And I think I did that week experience a little bit of the symptoms from Dressler, but by the following Saturday, we went down to Johnson Space Center and walked around all day. I felt fine. I was taking it easy and realizing that I had to move a little slow, but everything was just perfectly good.
Well, Johnson Space Center, for those who don't know, it's about a 45-minute drive from Houston, 30 to 45 minutes, and then it's a campus. So it's not just a museum. Did you go on the on the trams to the other buildings. So
Yes,
I mean that's
we did. It is a great experience. You get to go see the mission control room that they featured in Apollo 13, the movie, and where it all actually happened.
Yep.
So it's a great place to go.
But my
experience.
point is, you weren't just sitting in a auditorium; you were out moving around the campus.
That's right. I was walking around. Yep.
Yeah.
And then the following Wednesday was my follow-up with you, and you cleared me immediately to go play golf again, which, as you can see from my background, is what I love to do. Played it again today. I play about twice a week, and I did take a little bit of time, getting my heart rate up in terms of cardiovascular exercise. So the other thing I like to do is play squash, which is racket sport. Kind of like racquetball, and so you move really good on that. And I just took my time and took it easy, but it didn't take very long at all for the recovery to set in and get me back to, I'd say, 100%.
Well, a lot of people with AFib go through this process where they're trying to figure out what the triggers are, and it's a maddening process. And then you try to change accordingly, and sometimes it works and sometimes it doesn't. It's very frustrating. And I think one of the great things about having something done that works is now you can go back and enjoy your life and you're not thinking about AFib every minute. Is that true?
Yes. 100%. You really get your life back. Especially, I know that there are people just from the Facebook group, which we should mention, that have been dealing with this for decades.
Yeah.
And they just suffer with it. And I'm going to say it's needless suffering now. So figure out what you got to do to beg, borrow, and steal your way to Dr. Wolf and get it fixed, because this is the way to get it fixed. And I'm the poster child for, yep, they tried to fix it one way and it didn't work, and so go get it done the right way. Dr. Wolf kind of makes me laugh because there were some other kind of sideline things that happened. I asked him for a referral to a cardiologist, and out in California here where I live, and he says, whenever someone asks me for a referral to another medical professional, I tell them to get on a plane and come to Houston. That's where everybody knows what they're doing. And I sort of laughed it off, but my experience has been, wait, you're exactly right. If you're going to go get anything serious done medically, go to the best place you can go. Don't go to the regional place, because even the regional doctor, when I was admitted that night, looked at me and he goes, well, there's things that we just don't see here very often. And it's really true. And that goes with ER doctors, and it goes with, any of this stuff. So do your research, which if you're watching this, you're doing, and, get on the phone to Kimberly tomorrow and get yourself on the waiting list. And
I think what I might have said to you, you paraphrased, I think what I might have said to you, I said I get calls from patients, I don't remember what state I mentioned, it might have been California, it might have been somewhere else, and they said, Dr. Wolf, do you know anybody around here, fill in the state or the city, what should I do, where should I go when I get AFib? And I said, go to the airport and get on an airplane.
Yeah, for AFib, absolutely. It's 100% true.
Here's another.
And, it does seem sort of strange that no one else does exactly what you do, because it's so effective. And I guess there's all sorts of different iterations of this procedure. But
Yeah.
Go to the guy that invented it.
Here's a question for you. Are you back to 100% or to your old self after the procedure?
Yes, absolutely. Like I said, I've been playing squash. I have been. I'm actually next month going to be going to do a 2-day very mountainous mountain bike ride. So I'm 100%. I don't even think about it anymore.
Yeah, I'm sure you got things to worry about, but it's not AFib right now.
Yeah, there's always something when you start getting to be my age. Stuff starts to. You start to have leaks here and there.
Here's an interesting factoid. There have been 3 people that I've taken care of that have since gotten a hole-in-one after the procedure.
Oh, well,
I was serious.
Close today. I was close today, but I've still never had one. So, your mouth to God's ears. Let's go.
It's too soon to say, Trent. Is Trent still on amiodarone?
Nope.
All right. What medications is Trent taking?
The only medication that I'm taking right now, sort of against
Better
my
judgment.
will, yeah, better judgment, is I'm on a very low dose of a statin. I've kind of been a carnivore eater, and but as I study up on it more, I realize that a lot of cardiologists will just give you a statin without even giving you much more information than that. So I'm on a very low dose of norvastatin, and then I take some supplements. That's about it.
We do a CT scan on almost everybody before the procedure, and the CT scan that's done here at Methodist is quite detailed, and it will tell if someone has significant coronary atherosclerosis or blockages of the coronary arteries. Now, as I recall, you didn't have any.
Oh, no, actually, let me correct your memory.
Okay.
This was sort of funny, and part of the story was on that Saturday before the procedure. I'm sweaty and having just gotten back from that 6 mile walk and in the apartment, and you called me directly.
Oh, okay.
And you don't beat around the bush. You're like, Trent, this is Dr. Wolf. You said the first thing you said is, where are you? And the second question was, how are you feeling? Any chest pain? And I said, no, I just walked 6 miles. And he said, well, your CT angio showed about a 70%, I don't know, what do you call it, occlusion, blockage, something like that. It wasn't occluded, but it was, narrowing.
Yeah.
And that's when you asked me, do you want to go through with this thing, or do you want to, go see a cardiologist? And I said, well, I don't know. I'm not a doctor, but all I can tell you is I've been waiting for this for 12 months. I had to fight tooth and nail with my insurance company to get here. And darn it, if I'm going to have a heart attack, I can't imagine a better place to do it than on your table.
Now I remember that. I remember that now. So you are being followed for a blockage, but not a significant one.
Yeah, right. After I had all this done, I went to UCLA, which is an hour from me and a pain in the butt to get to. Went to UCLA because they've got a really good heart program. And they did a nuclear stress test on me, and it came back normal. So whatever occlusion I've got that you guys showed, it's flowing through there just fine. So hence a little bit of statin and some vitamin K12 and vitamin D together, or K2, whatever it is.
That's good. From time to time, we pick up on significant blockages that nobody's noticed before. That's one of the good things about the CT scan. It shows whether or not there are any blood clots in the heart, whether there's a blood clot in the left atrial appendage, which would preclude the minimally invasive procedure, but I'm almost never seen. I mean, it's very rare. And then it shows things like when the anatomy is not normal. Reminds me of one fellow out your way. He's your age. I think he's 55. Lives in San Diego. Had 3 ablations. Then he had the convergent procedure where the surgeon went up underneath the breastbone and just burned the bejesus out of the back of his heart. Still had the same problem. And he came here, and we did the CT scan, and not only he did not have coronary disease, but what he did have was an extra vein on his heart. And we know that these extra veins can be very arrhythmogenic, means they can cause arrhythmias. And nobody had picked that up before. 3 ablations and a heart surgery. We made sure we treated that extra vein, and that was 4 years ago, and he has had no further AFib, and he's off all medicines. So the CT scan is good for telling whether or not there's any coronary disease. It's good for seeing if there are any blood clots in the heart, and it's very good also for seeing if someone has some unusual anatomy, which sometimes makes them more prone to this arrhythmia. Question for
I may die of a heart attack, but if I do, I'm going to be in rhythm when I do.
All right, that's all that counts. Another question, kind of, I guess, for both of us. What was the cause of Trent's condition, hereditary, diet? Well, if we figure that out, we'll share the Nobel Prize in medicine because we don't know. But there is generally a hereditary component, not always. And you mentioned that you have some people in your family that have suffered from AFib.
Yep, my mother had it, and she had an ablation sometime, 20-something years ago. She's no longer with us, but she had it and had it fixed. and my sister had SVT, the supraventricular tachycardia, and it still is a competitive swimmer. She was a college swimmer and very fit. So I don't know what the answer is to any of that. It does suggest that there's some hereditary nature to it, but as you say, I don't have a Nobel
It's
Prize
probably
in
both. It's her hereditary component and environmental component. We see it in athletes. I've taken care of a lot of cyclists, a lot of runners. Sometimes the cyclist or runner will tell me, or the runner will say, I'm a marathoner, I get to mile 17, that's when I get it.
Wow.
They get the procedure, they don't get it anymore. Now, one other thing I wanted to cover with you, you mentioned it before we came online here, is that it is normal for your heart rate to stay in a tighter range after this procedure. I believe that most people are born with their own pacemaker, their God-given pacemaker, that's happy to beat it 60 times a minute your whole life. That's where it wants to be. But you have all these nerves coming in saying, it's a scary movie, increase your heart rate. Hey, you're looking over the edge of a 100-foot fall, increase your heart rate. And it's that stuff that gets you out of rhythm, but that also leads to heart rate variability, which some people say is good, but too much heart rate variability is not good. So one of the things this procedure does is it decreases that heart rate variability. But you have to do that if you want to get rid of your AFib. Your heart rate may be a little bit higher than normal. In some patients, it's a little bit lower than normal because some of the nerves are saying go faster, some of the nerves are saying going slower, and everybody's wired a little bit differently. But you really want to see your heart rate variability narrow for a while. And that means it won't be it won't be bombarded so much with information from your brain and from your spine that allows it to go out of rhythm, if that makes sense. Let's see. What's the percentage of people who have AFib? It's estimated in the next 10 years it'll be about 10 to 12% of the population. Right now it's maybe around 10 million people. It may be more because, as you mentioned, some people have it and they really don't diagnose it until it gets really bad. We don't know. And we did a study a long time ago. We had people wear a monitor and keep a diary. And half the people knew the minute they went out of rhythm and the minute they went back in rhythm. The other half had no clue. So half the people I see only know they're out of fib because they're short of breath. The other half can tell me the beat they go out. So we're all wired a little differently. This one's for me. Dr. Wolf, what is the most common post-op complication that you run into? Well, it's probably what you described. I think, Trent, you described it very well. It's still only less than 5%, but we still see it from time to time. And I guess you were mentioning to me that maybe, you may still have gotten it, but we got the post-op instructions kind of screwed up, right? So instead of taking the 5 pills right away and then 4, 3, 2, you were just taking 1 a day.
Well, you're being gracious. My wife would say that as the one who is managing my meds, she was the one that didn't notice the instructions, which is an unusual thing for her. But yeah, she was giving me 1 of the steroids a day rather than the 6, 5, 4, 3, 2, 1 in as many days.
Well,
dosage.
We're not going to blame your wife. That would not be very smart. You got to keep the goddess on your side, right?
Hey, yeah, between she and you, that's the only reason I'm still alive.
So we're about out of time. I would like to thank you for joining us for this webcast. Thank you for allowing people to email you if they wish, if they had further questions at trent@losadams.us. Also, I wanted to mention to people that the way we've changed this now, this is the first time around, that after this webcast is over, it will be live on DeBakey YouTube almost immediately, right? Is that right, George? And if you have questions, if you're viewing this after the live event, there's still an opportunity for you to ask a question. And if we get questions, we'll address those the next month. Let's see, this is September, which would be October, first Tuesday in October. Any closing comments, Trent, for the people out there? And thanks for your time.
Oh, it's my pleasure. Yeah, I would say if you're wondering about this, wonder no more, and take whatever necessary steps you need to do. I would also be remiss if I didn't mention the Wolf Procedure Facebook group, which is a group you can get admission to, and I think that they probably have the answer to every single question you could ever have in that group. Everything from side effects to trigger things to where should I stay when I go out there, and what again is the name of that really nice guy that'll pick me up at the airport. Everything you can imagine. It's just a wonderful, supportive group with encyclopedic information. So
I'm glad you mentioned that.
Who runs that?
Sandy Schremeyer graciously runs that Facebook site, and she is a nurse. She was in the medical profession. She said she retired, but really she's got a full-time job running that site. And she had 3 ablations, and then she came here, I think it was 7 years ago now, and she's a wonderful resource. So yes, there's also a website called wolfprocedure.com, which has videos on it, and that's accessible to anybody you can get on their computer. So I guess in closing, I guess we have time for one more question. Okay, this one's for me, Trent. If I have a thyroid condition, can you prescribe an alternative for amiodarone that can effectively address flutters after the Wolf procedure? Well, there are 2 ways to look at it. One is to use a lower dose of amiodarone. And the reason there's a connection between the thyroid and amiodarone is in the middle of the amiodarone molecule is iodine. That's what makes amiodarone work. It's got iodine in the middle of it. So amiodarone is about 33% iodine, and it's very effective, but it can be very effective in very low doses, a half a pill, a quarter a pill. So that's what I usually recommend, using a much lower dose until you can get through this and get off of it. There is a molecule that became a drug, and it's called Multac. And Multac is the amiodarone molecule without the iodine in the middle. So it doesn't have the same side effects that iodine can have. Unfortunately, it doesn't work very well. That's the only problem. They made a cool molecule without the iodine in the middle, but I don't think it's very effective. So generally, what I recommend is to decrease the dose because we've noticed that after the procedure, a much lower dose is still effective, maybe a quarter pill a day instead of 1 pill. So that would be my short answer. Trent, thanks for joining us. I hope you get the hole-in-one. That'd be number 4. Please let me know if you do. We'll add you to the list. In the meantime, enjoy the autumn in California. And thanks for joining us here at DeBakey CV Live, or now it's called CV Now.
My pleasure. Thank you.
Take care.